Welcome, everyone. We'll just give it a minute and then we'll start. All right, we'll start now. Good morning, afternoon, evening, everyone, and welcome. Thank you for joining us for the launch of the updated WHO guidelines on risk reduction of cognitive decline and dementia. My name is Primrose Nyamayaro, and I'm a consultant in the Department of Non-Communicable Diseases and Mental Health at WHO headquarters, and I'm delighted to be your moderator for today's launch. We can move on to the next slide. Thank you. So before we begin, we just have some housekeeping notes. We have simultaneous interpretation available in French, Portuguese, and Spanish. So please select your preferred language using the interpretation button that is on Zoom. It's one of the options at the bottom of your Zoom screen. We encourage you to share your questions throughout the webinar using the question and answer function, and we'll address as many questions as possible during the discussion session later. And please note that this webinar is being recorded and it will be made available after the event. Now to start, I can see people already posting in the chat, but if you can let us know in the chat in one word, what comes to mind when you hear the phrase dementia risk reduction. So you can enter this word in the chat. You can enter it in English, in French, in Spanish, or in Portuguese. I'll try and keep up with what everyone's typing, but I see some people are saying hope, some memories, lifestyle, prevention, being proactive, empowerment, education. As we see these responses coming through, it's clear that dementia risk reduction means different things to different people. And throughout the session today, we will explore how these perspectives come together to reduce the risk of cognitive decline and dementia. Now, to set the stage for today's webinar and to reflect on the importance of dementia risk reduction, we will hear opening remarks from the WHO Director General.
Dear colleagues, partners, and friends, thank you for joining us for this launch of the second edition of the WHO Guidelines on Risk Reduction of Cognitive Decline and Dementia. Dementia is among the greatest health and social challenges of our time, touching people, families, and communities everywhere. Its impact on dignity, independence, and well-being reminds us that directly or indirectly, we will all be impacted at some point and share a responsibility to act. There is also hope. We know that prevention and management of risk factors throughout life can reduce dementia incidence significantly. These updated guidelines provide practical, evidence-based actions to reduce the risk of cognitive decline and dementia. That includes recommendations for healthy lifestyle, better management of health conditions, and improving environments. Protecting brain health is not the responsibility of the health sector alone. It requires coordinated action across governments, communities, and systems. WHO calls on all countries and partners to integrate dementia risk reduction into primary health care and programs to address non-communicable diseases. Together, we can change the trajectory of dementia and build healthier, more resilient societies. I thank you.
Thank you to the Director General for that powerful message on the importance of taking action to reduce our dementia risk. Now, before we turn to the technical content of the updated guidelines, it is important to remember why this work that we do matters. And we will hear from Emily Ong. Emily Ong is a dementia advocate whose lived experience with cognitive decline has made her a leading voice in Asia and globally. She has co-founded several initiatives to support people living with dementia and is passionate about reducing stigma, promoting inclusion, and empowering individuals through peer support and practical resources. Emily, thank you for being here today, and the floor is yours.
Thank you. So, good morning, good afternoon, and good evening. My name is Emily Ong, and I'm joining you from Singapore. It is a privilege to participate in the official launch of the WHO Guidelines on Risk Reduction of Cognitive Decline and Dementia, second edition. I'm here today both as a person living with cognitive decline and as a member of the Guidelines Development Group. Contributing to these guidelines has been both professionally rewarding and personally meaningful. It reaffirmed that when people with lived experience are genuinely involved, recommendations become not only evidence-based, but also practical, human-centered, and relevant to everyday life. One of the most important messages that you must take away is that risk reductions and brain health remain important throughout the life course, including after a diagnosis of cognitive decline and dementia. People living with cognitive decline and dementia can also benefit from addressing modifiable risk factors. So these guidelines matter to us too. Although we cannot yet reverse the underlying disease, growing evidence showed that this intervention may help maintain functions, preserve our independence, improve quality of life, and potentially slow further decline. From my own experience, these recommendations are not simply clinical guidance, but they are practical strategies that help me continue living as well as I can. Physical activities help me maintain my mobility, concentration, confidence, and ability to stay engaged in daily life. Healthy eating is equally important. Because I experience chewing and swallowing difficulties, I have adapted the way I prepare and cook food so that I can continue to enjoy safe, nutritious meals while maintaining both my dignity and brain health. These may seem like small actions, but they give us something invaluable, the opportunity to remain active partners in managing our own health and well-being. At the same time, individual effort alone is not enough. Like just now what the director said, successful implementations of these guidelines requires coordinated action across healthcare systems, governments, and communities. We need healthcare professionals equipped with evidence-based knowledge to guide us, supportive and dementia-inclusive communities to enable us to continue to live within our own communities, recognition for the care partners who are caring for us, and sustained investment in prevention, risk reduction, and brain health. I would like to express my sincere appreciation to Dr. Tarun Dua, Dr. Catherine Sheha, and the WHO team for their genuine commitment to meaningful engagement with people with lived experience throughout the guideline development process. which is, I think, is about 2 years, if I'm not wrong. I particularly remember our meeting at the WHO Academy, Lyon, where the group has to revisit earlier discussion because I need more time to process the information before sharing my views. Rather than feeling limited by my cognitive disability, I feel respected, included, and empowered to continue. For me, that truly embodies the principle of nothing about us without us. As we launch these updated guidelines today, I hope they will be more than a scientific and policy resource. I hope they become a catalyst for action, one that inspires countries to invest in brain health, empower people to take an active role in managing their health, support families and care partners, and enable people living with cognitive decline and dementia to live as well as they can with dignity and purpose for as long as possible. Thank you for having me.
Thank you very much, Emily, for sharing your personal story and also the practical steps that you take to reduce your own dementia risk, and also highlighting the importance of having this lived experience voice throughout this guideline process. Thank you very much.
Thank you.
We will now turn to the updated WHO guidelines. And to present the guidelines, highlight what is new in the second edition, and also to discuss their implications for policy and practice, I will hand over to Katrine Siha. Katrine, over to you.
Thanks a lot, Primrose, and thank you, Emily. After more than 2.5 years of being in the making, I think it's fair to say that these updated guidelines have extended any elephant pregnancy in terms of gestation duration. So it is a great pleasure for me, honor, and also big relief to present this big baby to you now. The updated guidelines really address one of the biggest elephants in the room, the ever-rising number of people living with dementia, but then also our common and shared goal of changing that trajectory for future generations through risk reduction and prevention. Risk reduction is also a primary focus of the now extended Global Action Plan on the Public Health Response to Dementia, where the vision clearly states that we're looking for a world in which dementia can be prevented, and people living with dementia and their carers live well and receive the care and support that they need. But when we actually look at country-level action, we see that not even half of the countries that participated in the last round of WHO's Global Dementia Observatory reported having evidence-based national guidelines for dementia risk reduction. So that clearly indicates a need. But why update the guidelines that we had in from 2019? Well, the answer is short and probably not so surprising. The science has advanced tremendously over the last 5 to 6 years, with the evidence base being expanded, not just on the 9 risk factors and 14 recommendations that had been included in the previous version in 2019, but also on new risk factors, for instance, and also on areas where previously we had insufficient evidence, so we could not make a recommendation back in 2019. Importantly, science has also advanced on approaches to risk reduction, so not only focusing on individual level interventions, but also looking at population level interventions or multi-domain interventions. So the evidence base expanded on all levels that you see here, prominently into many of you probably known through efforts such as the Lancet Commission on Dementia Prevention, Intervention and Care. We do know what factors are associated with an increased risk of dementia. That is the blue path here on the slide. We also, compared to 2019, now have many more WHO guidelines and other national guidelines on what interventions work on treating risk factors. But what we didn't know before the guideline update is what interventions are actually effective in reducing the dementia risk or ultimately lowering dementia incidence. And that is the main scope and aim of the updated guidelines. To address this gap, we followed this process that you see outlined here on the slide. It is guided by WHO's Handbook on Guideline Development, and the entire process was only made possible through the strong support from the Public Health Agency of Canada. So thank you very much at this stage. So we started back in 2024 with a scoping of the literature, trying to map of what are the areas with the biggest increase in evidence since 2019, and what potential new interventions or risk factors were there to include. Simultaneously, we established a network of guideline contributors. Many members of our WHO steering group, the guideline development group, the evidence review teams, and the peer reviewers are joined here today. So thank you again for your contribution. The evidence review teams then synthesized the evidence for 16 different research topics. And I'll come back to that in my next slide. But just to conclude the overview of that full update process here, the Guideline Development Group, or GDG, then reviewed all the evidence that was presented to them, critically assessed and weighed the harms and the benefits with equity considerations, for instance, and made very careful formulated recommendations. These recommendations were included in the draft guideline, which was shared with a wide range of external peer reviewers before then internally cleared by WHO and ultimately designed and published today, as you can see it now. So which risk factors were considered in the guideline update as intervention targets? You see them presented here on the slide grouped into four bigger categories. So there's on the one hand, the health behaviors, or termed as risk factors, the unhealthy behaviors. So cognitive inactivity, social isolation, physical inactivity, tobacco or smoking, harmful use of alcohol, and unhealthy diets. You also see the largest group, which are health conditions or biological states that we know carry a certain dementia risk. These are cardiometabolic conditions like obesity, diabetes, hypertension, and dyslipidemia, but also sensory function, hearing loss or vision impairment, stroke, traumatic brain injury, depression, poor sleep, early or premature menopause, and HIV. We also included in this update for the first time environmental factors, namely air pollution, and a category for addressing risk factors more holistically through multi-domain interventions. Evidence synthesis or full reviews were completed for all these factors that you see here, except for four, and they're the ones that are underlined: physical activity, tobacco, alcohol use, and dyslipidemia. And that was because through the scoping exercise that was done at the beginning, it was considered that the evidence base for those is not changed in a way that the recommendations for those would change. And the factors that have been added in this edition are now marked here on the slide with an asterisk. This is the slide that most of you have probably been waiting for eagerly, because that is the summary of the 2026 recommendation. There continues to be 3 strong recommendations for physical activity, smoking cessation, and not using dietary supplements for the sake of preventing dementia if there is not a diagnosed deficiency. Now, what do strong recommendations mean in the guideline development process? They generally mean that these should apply to most people. There's good evidence and strong certainty that they will have the intended effect. The guideline also makes a range of conditional recommendations that you see here in the middle. Conditional means that the benefits still probably outweigh the harms, but the confidence in that trade-off is lower. And that could be, and actually is in the case of dementia risk reduction, often due to methodological limitations that the evidence that we have at hand is facing. For example, limited, robust, long-term clinical trial data. So the recommendations in that area pertain again to managing cardiometabolic conditions such as hypertension, diabetes, dyslipidemia, and obesity, but also promoting healthy, balanced diets, reducing harmful alcohol use, or, for instance, now added air pollution. These factors are commonly shared with other NCDs, and that sends really the strong signal that there's huge opportunity for joint and integrated action. But importantly, dementia risk reduction also comes with a very specificity in the sense that promoting cognitive activity, social activity, and, for instance, the effective management of hearing loss come with very specific benefit for dementia risk reduction. The same is true for multi-domain interventions. Interestingly, the guideline discourage the use of menopausal hormone therapy in women over the age of 65 for the sole purpose of reducing dementia risk. And they also found insufficient evidence to advise for or against in younger women. Now, what does that mean clinically? That the decision whether or not to take menopausal hormone therapy, to continue or to stop, should be based on other factors, but not on whether or not it influences dementia risk. We also reviewed the evidence for a whole set of other factors, as I mentioned, but the evidence was insufficient to make a recommendation in those areas. That includes the treatment or management of vision loss, sleep, HIV, traumatic brain injury, stroke, depression, or the use of menopausal hormone therapy in women younger than 65. Now, importantly, these guidelines or these recommendations do not replace any of the other WHO existing guidance for those risk factors. What they merely do is they complement them. And in the guideline document, once you look at it, you will see that there are clear or long comprehensive lists of how the dementia recommendations complement and work kind of in unison with existing WHO guidance. Now, you might ask what factors affected the certainty of the evidence, or in many ways the insufficiency of evidence. In many instances, robust interventions with kind of like longer, large clinical trials, they're missing for dementia risk reduction. But dementia is a very long-term outcome. It requires studies or trials to go for very long periods, which is very costly and sometimes simply impractical. So conducting shorter trials or using cognitive function outcomes rather than dementia as an outcome are workarounds, but they come with the risk of reducing our ability to make really certain assessments of the intervention effect. Similarly, conducting trials in older cohorts that would require shorter follow-up periods also carry the risk of methodological flaws or complications such as reverse causality. Across all areas and risk factors, it became clear that the evidence continues to be generated primarily in high resource settings. That's not only limiting our generalizability, but it also sends a clear signal of inequity and a call for action. It also highlights the importance of tailoring the recommendations included in the guideline to the specific context, to the setting in which they will be used. Many dementia risk factors also are shared or interact with each other, and so do interventions to address them. So it is sometimes tricky to disentangle what is an intervention effect for which risk factor, and we all do know and I think appreciate how complex and difficult it can be to change behavior long term. But lastly, I think I want to remind us all that the fact that for many areas there's insufficient evidence should not be interpreted as that these interventions may not be effective, but merely as a signal that research or evidence generation is fast evolving, and really more intervention data and evidence needs to be created across the whole globe in order to address those evidence gaps. Now, while the guideline update process is more or less complete now with the launch of the guidelines, our work is far from being done. We have the guidelines now. Now we need to use them to empower individuals to adopt and maintain healthy behaviors, to strengthen the health systems, to integrate dementia risk messaging in primary care, in NCD programs, and healthy aging programs, and also to inform policy dialogue to protect brain health for all. Across all these areas, or this brain health pyramid, WHO, across its 3 levels, the headquarters, regions, and countries, across the different departments and programs that have all been involved in updating those dementia guidelines, we're actively supporting our member states in making this happen. Just to give you a few examples, for instance, we are developing or updating knowledge summaries or campaign material. We're creating or updating course materials and training for healthcare workers. And some tools are already existing. And we advocate for policy change. For example, our colleagues working on physical activity, they're currently updating their estimates for the cost of inaction on physical inactivity. So let me finish by thanking the over 200 contributors that made together this guideline update possible. Our GDG members, the guideline methodologists, the evidence review teams, peer reviewers, people with lived experience, and the huge group of WHO colleagues who've all either actively or behind the scene contributed to making this launch possible, this guideline update possible. So huge thank you from our side. And with that, I hand back to you, Primrose.
Thank you very much, Katrine, for that comprehensive overview of the updated guidelines. In the question and answer on Zoom, we already have a lot of questions that are being asked, and we'll do our best to continue providing answers for those. So we've heard about the evidence, we've heard about the recommendations. We'll now take a few moments to watch a video in which some of the guideline contributors that Katrin mentioned just now, both external and internal from around the globe, share what dementia risk reduction means to them and what it can mean in day-to-day life. So let's watch the video together.
Dementia isn't an inevitable part of aging, but many of its risk factors are within our control. Here's what experts recommend. It starts with one simple habit. Keep moving.
A walk in nature is more than a break. It is a simple act of care for brain health. Pickleball is more than just a game. It is a powerful tool for brain health that merges physical activity, mental agility, and vital social interaction. Embracing this sport is my personal commitment to staying socially and physically connected. I take part in the Memory Walk, which has been held annually for the last 15 years and encourages us to keep our brain active and prevent dementia. To maintain my brain health, I really enjoy getting out in nature on my bike while wearing a helmet, of course.
What we eat matters too.
Cook fresh, eat right, live bright. I always enjoy the art of healthy cooking with family and friends. Making healthy food choices is one way I support my brain health every day.
And just like our bodies, our minds need exercise.
Cognitive training increases my brain resilience and improves my brain health. I keep my brain active by learning new things.
Brain health isn't only personal, it's also social.
Staying connected supports my brain health. I stay socially connected by running and making music together with my sons.
Some habits protect the brain, others put it at risk.
I enjoy low sugar mocktails because my brain works better with less alcohol.
And some habits are worth leaving behind. Quitting tobacco is one of them.
Dementia runs in my family. Quitting smoking after 15 years was personal for my brain health and my freedom. No more organizing my day around the next cigarette.
Some risks are easy to miss. High blood pressure is one of them.
I check my blood pressure regularly to protect my brain.
Managing blood sugar matters too.
I make balanced food choices to help reduce my risk of type 2 diabetes and support long-term brain health.
Protecting your hearing can also protect your brain.
I protect my hearing so that I can continue to enjoy live music, socializing, and connections that actively stimulate and protect my brain health. Hearing aids help me engage in conversations and connect with the people around me. They empower me to keep my auditory system active and support my brain health.
Managing chronic conditions is part of long-term brain health.
I keep my brain active by learning and doing new things. For example, every week I write an article for a weekly column, which is published in a newspaper in Uganda. For people living with HIV like us, taking HIV medication every day is the best way to support our brain health.
Sometimes, protecting your brain starts with preventing injury.
Looking after your brain includes protecting it from injury. That's why I always wear a helmet and high visibility gear when cycling around London.
And some risks aren't personal, they're environmental.
I bike for my health and for the planet, and I choose less polluted routes and times whenever possible.
Dementia risk isn't shaped by one moment. It's shaped by the moments we repeat every day. How do you protect your brain health?
We hope the video has provided some practical insights and also some examples of what we can all do to protect our brain health. I now would like to know a bit more about who's joining us today and also hear your initial impressions of the updated guidelines. So you'll see on the screen a few short questions that will appear. And please take a minute to complete the questions as they appear. I hope they are showing on your screens. Katrin, could you confirm if you can see the questions?
It was there. Yes, it's there.
Thank you. Yes. We'll just give you a minute to complete them? All right. Great, thank you. Thank you to everyone who has participated, and thank you for your responses. We'll now move to our panel discussion, which will be moderated by Tarun Dua, where we will explore what these updated recommendations mean in practice and also discuss opportunities for implementation and future action. Tarun, over to you.
Thank you, Primrose. Hope you can hear me well.
Yes, I can hear you.
So we have a very distinguished panel today. Noha Sabri, Cluza Ferry, Carla Recknagel, Muthoni Gichu, and Chris Lynch. So welcome to the panelists. Good morning, good afternoon, and good evening, because you're joining across the world. So I'm going to start with Noha. Noha, are you online? If you can, and is your video on? Yes. Great. Yeah. So Noha is a professor of psychiatry at Cairo University and leading expert in old age psychiatry and mental health in Egypt. She has played a key role in advancing mental health research, services, and training, and brings the expertise in aging, mental health, and dementia together. So, Noha, I think this is a right question for you. As a clinician, what are the key messages that you take from the current evidence that Catherine provided on dementia risk reduction?
It is great being with you in this very distinguished moment, having these guidelines, which highlighted very important messages. First of all, it touched me a lot that optimizing brain care should start along the life course. It should not be started at late in life. It should be started since early childhood. So caring of our brain and our brain function along our life is very important and should be promoted to all our clinicians and all our clients. And we should direct this to reduce all the cognitive decline in normal and as well as to those who are suffering from MCI and early in dementia also. There is always hope to do something with this. It is very important to maintain healthy lifestyle. I think it is mandatory to start with physical activity, as the video showed, having which type, like aerobics, strengthening activities, choosing appropriate diet is very important. And many diets is now evidence-based, like the Mediterranean diet, and it is very important not to localize to certain types of food. It should be open, and we should be patient-centered, so allow the patient to choose their own choices. This is very important. Also, to avoid the harmful uses of alcohol and to stop as much as we can. The tobacco is very important. It is well evidenced, and now it is more emphasized by these guidelines. It is very important, being clinicians, to management all the health conditions that contribute to that might contribute as a risk factor, like treating hypertension, diabetes 2, dyslipidemia, strokes, high incidence of stroke. Very important to check for the sensory problems, hearing loss and vision is very important, to making like a regular checkup about it. And although management of depression is not one of the proved evidence, however, we should treat the depression in whatever mean by psychological interventions, antidepressants. It is important, and not to mix it as a proper risk factor for dementia. Management of HIV also is very important. We should put it in our consideration all the time. Taking care of our pollution is also very important, and it's very, very important that many of these factors are intersected together and connected together. So taking care of everything is very important. One very important thing is not to over prescribe non-needed vitamins or drugs that is not needed, because and connected it with prevention of dementia. So I think this is a great point to recommend, and also not to make launching for hormonal therapy for menstruation as a way to protect against cognitive decline. This is very important, being clinician, not to over prescribe not needed medications, and to go back to what is healthy, what is evidenced, and to stick to it.
Thank you, Noha. I think two things that are important takeaway message from what you said. One is the life course approach, and then integrated person-centered approach. I think that we take into account what are the risk factors and tailor our strategy accordingly. And this is, I think, a good segue into inviting Clusa Ferry, who's a psychiatrist and epidemiologist from Federal University of Sao Paulo in Brazil. And she has been a collaborator for many, many years. Clusa, I'm trying to remember when we first met, and advancing dementia research policy care for so long in Brazil as well as globally. So Clusa, as we heard about the limited evidence, and we heard about the challenges in doing dementia risk reduction research. So as you look at the evidence base, how do we move from the association evidence from evidence on interventions? How do we balance the some of the intervention strategies are individual level, some are population level. So how do we balance all that together? So tell us, from your epidemiology and psychiatry background, what is the best way forward?
Hi, Tyrone. Thank you. First, congratulations to the 200 contributors to this amazing document. I think that will be very useful for many around the world. And it's a pleasure to be here. And just to start, I would like to remind you that we already know, I think Catherine in the beginning have already said that we know for the last few decades that many epidemiological studies have been identifying, bringing more evidence on the risk, the factors that are associated with dementia risk, and we know we have said all of them here today. But translating, as your question, translating this growing evidence into what we could call effective interventions that reduce dementia burden for the future, I think it is still a big challenge. And I think this document brings a contribution, but we have many things still to grow and to improve. So I think I just would like to start saying that it's already very difficult to establish that certain factor is really increasing or decreasing dementia risk, because we also don't know exactly by how much it does and their clinical relevance and which time in life they may be more or less likely to contribute or to increase or decrease the risk of dementia in late life. But I think like the Lancet Commission has done a very good, meticulous work on establishing the main risk factors for which the evidence is more robust. And we have several challenges to do that itself, to establish that. For example, someone have mentioned, I think Catherine, reserve causation. And for example, if you reducing physical activity or social engagement, for example, they could be early symptoms of dementia rather than independent causes. So as a result of that, depending on when the intervention targeting these factors, for example, it is offered, and to whom they are offered, they may not produce the effects that one would expect. And I think just is to call attention to that. Another challenge that has already been mentioned as well is the long-time course of dementia. We know that Alzheimer's disease and other dementias develop over decades. So it means that interventions may need to begin in midlife or even earlier than that to really produce benefits that are measurable. And you know that conducting randomized controlled trials over such a long period, it's expensive, as Catherine has said, in many ways, impractical. So we end up relying short-term cognitive outcomes, and these may not fully predict long-term dementia prevention. And remind everyone that dementia is a complex multifactorial condition. And so risk factors, they interact with one another across the whole life course, alongside with the genetics and broader social determinants of health. So it's unlikely that a single intervention will substantially reduce risk. And there is this evidence that still needs to be built up to make this even stronger. We have now evidence of this multi-domain intervention that combine exercise, diet, management of the cardiovascular risks and cognitive stimulation, social engagement. They may be more effective, but this type of interventions, I think they are even more complex to implement, and their effects may be substantially different between populations. And even when evidence supports an intervention, achieving sustained behavior change at scale is very difficult. And I think everybody knows that from their own experience. Lifestyle modifications require long-term motivation, supportive environments, and equitable access to health care and community resources. So individuals with lower socioeconomic status often face greater barriers to adopting healthier behaviors, potentially widening health inequalities, even if interventions are not designed with equity in mind. So I think this, what I said now, comes to the second part that you asked about individual and population level interventions for dementia risk reduction. I think individual level interventions remain essential. I think healthcare professionals can identify people at higher risk, can manage vascular conditions, as we said here, hypertension, diabetes, can encourage smoking cessation, promote physical activity, and provide personalized advice on healthy aging. And tailored interventions can account for an individual's health profile, preferences, and readiness to change, making them particularly valuable in clinical settings. However, focusing only on individual responsibility is unlikely to achieve the greatest population impact. So many dementia risk factors, they are shaped by social, economic, and environmental conditions beyond personal control. Educational opportunities, access to care, to healthcare, neighborhood design, air quality, food environments, and policies affecting, for example, tobacco and alcohol use, they all influence dementia risks throughout life course. So population level interventions play a critical role. Policies that improve cardiovascular health, reduce smoking, improve hearing care, reduce air pollution, and address educational inequalities may produce modest benefits for each individual, but substantial reductions in dementia burden across society. But I'd like to say that rather than viewing these as approaches as competing, I think we should be seen as complementary. Individual interventions are most effective when supported by environments that make health choices easier. And population policies create the conditions in which individuals' behavior change becomes more achievable and more sustainable. So just to conclude, The pathway from identifying dementia risk factors to implementing effective prevention strategies is complex. I think this is clear. Strong observational evidence must be complemented by rigorous intervention research, long-term evaluation, and careful consideration of implementation in real-world settings. The greatest success in reducing dementia risk is likely to come from integrating personalized clinical care with broad public health policies that address the social and environmental determinants of brain health across the life course. So I think that if you can combine this, we can have the best opportunity to reduce the future burden of dementia and promote healthier aging for everyone. Thank you.
Thanks, Clusa. I think and you very nicely provided the summary, and if I can take it forward, for a sustainable and scalable action, it's a systems approach that is required. We need multi-level response, individual level, health systems level, policy level, and multi-sectoral response. I think it is not a single actor that can help us achieve reduction of all the risk factors and promote the protective factors. So thank you very much, Clusa. I'm going to move on to Carla Reknagel, and I know I'm pronouncing it awfully, but welcome.
When you're doing fine.
Thank you, Carla. Carla is a policy advisor at the German Federal Ministry of Health, and she has done all. She has been a frontline nurse, worked in care management and national health policy. So you bring all these different perspectives together. So maybe you are the best person to tell us, as you reflect on these from a clinical aspect to a policy aspect, how do you see dementia prevention in the updated German dementia strategy, and what lessons are there to be shared with other policymakers? Over to you, Carla.
Yeah, thank you. Thank you for the question, and also congratulations for the good and great guidelines. Thank you. And I would like to start to frame a little bit about our German, how the situation in Germany is. About our status quo here. Germany is among the oldest countries in the world. 20% of German people are over the age of 67. Approximately 1.8 million people with dementia are living in our society, and this number is to be expected to rise to up to 2.7 million by 2050. That means for us, dementia is a major challenge associated with changing demographics. Also, total annual costs of medical and nursing care for people with dementia in Germany was in 2023 by 21.5 billion euros. A study by the German Center of Neurodegenerative Diseases called DZNE, conducted by our well-known researcher Dr. Tirian, found out that around 36% of dementia cases in Germany are linked to risk factors that can, in principle, be influenced. Coming to our national dementia strategy. First, a little heads up about our timeline for the new NDS. The discussions regarding the specific from the continuation of the NDS will take from 2027 onwards are currently ongoing. A decision is expected by mid-2027. And of course, dementia prevention is set to be a key focus of the NDS continuation. The strategic goals are aligned with the 7 action areas of the WHO Global Action Plan on Dementia. Through this, we aim to ensure international compatibility and comparability. To achieving strategic goals, we use the interdisciplinary approach, which is an approach we already use in this ongoing NDS. Our distinctive feature now is 89 organizations form a broad alliance of stakeholders collaborating within the NDS. This network is to be strengthened and further expanded. Back to the new strategic goals in our new upcoming strategy and the idea behind it. The collaboration process with the stakeholders is to be organized into working groups. It will begin with 5 working groups. Work will take place in a 3-year cycle. And now we come to the importance we want to give dementia prevention in this updated NDS. During an initial 3-year cycle, there is to be a working group focused on the strategy goal, we are improving dementia prevention. The following priorities are possible for this working group, which is assigned to Action Area 3 of the WHO Global Action Plan. Prevention in medical and nursing care context, research on prevention, public education assigned to Action Area 3 in the WH structure, as well as mentoring of the most important risk factors for the development of dementia in order to track the effect of preventive measures. In October this year, we will have an annual NDS networking conference where we want to discuss further the possibilities for each upcoming working group together with all the stakeholders of our NDS. And you ask about lessons for other countries. First, I would say stakeholder participation and their involvement in the process of setting the agenda are crucial. We think about the stakeholders as our heart of the new NDS. When selecting the stakeholders, it is very important that they have a diverse working background. By that, I mean our stakeholder partners are from medical and civil societies, different government structures, science, health and long-term care insurance, and many more. To ensure international alignment and comparability, the focus should be on the action areas outlined in the WHO Global Action Plan on the public health response to dementia. Thank you.
Thank you very much, Carla, and congratulations to Germany for such a rigorous, systematic approach. And I think the message is very clear that unless and until we have a multi-stakeholder approach and all of those working collaboratively, we will not be able to achieve the vision and the goals. And I echo what Emily said in the beginning, right? Nothing for us without us. And really this support, this input of people with lived experience and their families and caregivers is extremely important. So thanks a lot, Carla. And let's move to the other continent. Muthoni Gichu from who's joining us from Kenya. She's from the Ministry of Health in Kenya and is a global health leader and brain health advocate. Dedicated to healthy aging and advancing dementia risk reduction. Dr. Muthoni has expertise in research, policy, advocacy, and has been working on strengthening brain health systems and promoting equity across Africa and globally. So you heard from Germany, and if Muthoni, you can share with us, what's Kenya doing in integrating dementia risk reduction into their NCDs and aging strategies? And what do you see as opportunities or challenges that have emerged from this approach? Over to you, Muthoni.
Thank you very much, Doreen. This is a very important question. And thank you for that question. And congratulations for getting to this point where we get to launch the guidelines again. So in Kenya, we have recognized that dementia cannot be a standalone. It cannot be a standalone issue. And then we also recognize that the risk factors for dementia overlap significantly with those of other non-communicable diseases, from hypertension to physical inactivity and everything else in between. So our approach has been to embed dementia risk reduction into the broader NCD and healthy aging strategies. So we're not looking at creating anything separately. So to start with, at the policy level, we're looking at, so we have had dementia prevention referenced and integrated within the national policy on older persons and aging, as well as within the NCD prevention and control frameworks. So this ensures that dementia risk reduction appears in budgets, in training curricula, and in monitoring systems. So, and then at the service level, when we look at primary care and community health platforms, we are leveraging those ones because we have actually a robust community health promoters system. And what does this do for us? It helps us deliver the prevention messages as well as simple screening for cognitive concerns. I'll give an example. When a patient comes in for blood pressure or diabetes management, that encounter is an opportunity by itself to talk about brain health and dementia risk. And a particularly exciting development is a longitudinal aging study in Kenya, which we're calling LOSHAC. This is the first large-scale effort to generate local data on aging and dementia risk factors. And LOSHAC is important because it provides evidence that is specific to our context, both rural versus urban differences in social economic determinants and cultural factors, and also provides us with data that we can compare with other health and retirement studies across the world. This data also helps us prioritize interventions that are most relevant to the Kenyan communities, and it strengthens our voice in the global conversations. So what opportunities have emerged from this integration? First, we see efficiency and synergies, because when we piggyback on the NCD space, we're able to see a reduction in the cost of bringing in the interventions, as well as we are able to scale to accelerate the scale up. Because these things have been going on, like NCD prevention programs have been going on, and also healthy aging. Again, with the community reach, Kenya, like I said, has a strong network of community health promoters, and they are able to deliver culturally adapted messages about brain health alongside other education, alongside other health education. When we look at brain health and brain capital, and I like this conversation because when we're able to frame dementia prevention as part of the broader brain health agenda, we highlight the role of cognitive resilience in economic productivity, social cohesion, and national development. That means that when we protect brain capital, it is not just a health issue. It is an investment into our present and the future. But this also does not come without challenges. So, for example, awareness and stigma in dementia. Dementia is often misunderstood, and this limits help seeking and timely seeking of interventions, and also community acceptance. And this means sometimes people get isolated. The frontline health workforce also needs practical training and job aids to integrate dementia prevention into routine care. And before LOSHAC, we had lots of data gaps. And that is why LOSHAC is very important in this space, because we need comprehensive national surveillance and indicators that are embedded in our routine health systems. And then the other challenge we're having is the inequities. Rural and marginalized populations risk being left behind unless interventions are deliberately targeted and resources distributed to the local context. So we have an opportunity here. That is a fact. This opportunity requires deliberate investment in awareness, in training, in data, and equity. So if we act on these fronts, which we are doing, it means that Kenya gets to experience, or it shows that Kenya can actually experience dementia reduction and become a catalyst for healthier aging and stronger societies, which is what we're looking at as a young country. And we have a population that's growing old relatively fast.
Thank you, Muthoni, and congratulations to Kenya for this integrated approach, leveraging of existing systems and really moving the agenda forward. I think the main takeaway message that I hear is that invest in brain health today for future gains. I think that is very relevant for all the countries. And this is, let me now invite Chris Lynch to, yes, here, Chris, who is acting CEO of Alzheimer's Disease International, and for more than 30 years of experience in healthcare advocacy, and been working very closely. ADI has been working very closely with WHO for many years in advancing the global response to dementia. So, Chris, welcome to this exciting event on launch of the guidelines. So, tell us, as a civil society, as a dementia advocacy organization at a global level, and also your national associations, how do you plan to take forward these recommendations? And so, really having recommendations is one thing, implementing them is another. So tell us, how are you going to help us in supporting and implementing these recommendations that have come out today?
Wonderful, Tarun. Thank you. Hello, everybody. Really delighted to be joining you for today's launch. I'm in London, but opposite end of the city to Tarun, unfortunately. We were hoping to get together. I've been attending the Alzheimer's Association Research Conference, which had an incredible 11,000 delegates in person over the last few days. And risk reduction research was right at the heart of it as well. It was so encouraging to see it. But look, congrats and a big thank you to you, Tarun, to Katrine, to Laura, to the whole team and the contributors for this updated guide. And lovely to see Emily on, and obviously DY and some of the ADI team and members have been party to this as well, which has been absolutely super. It's been really interesting thinking about this in all my years in the dementia space and in the development of national dementia plans. It's not until quite recently that risk reduction has started to become a core pillar of national dementia plans. And in fact, I think a lot of countries, when they developed their first round of plans, it wasn't included at all, which wasn't that long ago. So you see how far and how quickly this area of research and science has come. I mean, thankfully, it is becoming a core pillar and a primary focus for so many areas now. And one of the ones that I'm kind of most excited about in terms of sharing is the Swedish dementia plan, because it really is at the forefront of what's going on with that particular country's plan. But from ADI's perspective, you know that we've got a network of Alzheimer and dementia associations all over the world. So we're in 120 countries, and it gives us a perfect platform to raise awareness of risk reduction and to really start the amplification and distribution of these guidelines. And in addition, we've got our global audience, and that includes researchers and healthcare professionals, policymakers, governments, people with dementia, living with dementia, and carers. And they're getting our emails and social media posts constantly. So what we've also found is that there's an absolute eagerness for this type of content as well. So for us, it's just such a logical thing to be able to help distribute them. I think a key element for the success in terms of awareness raising for us for this, and also influencing implementation, as you said, is actually at the association level. But it's to make somebody at that national association level responsible for risk reduction, for the information, the advice, the support, the advocacy, everything that goes around it. And it doesn't have to be somebody directly in the team at the association. It can be an advisor, a researcher, a healthcare contact, a volunteer. But identifying somebody really is the key to it. There's so much information coming in, and the guidelines themselves are going to take some reading and absorbing and understanding, and somebody has to take responsibility for that. So we will help the associations to really start to pull that together. And look, a really important area, I think, Tarun, for us is this kind of intersection with non-communicable disease. And I was delighted that Mathoni just raised this as well. We know that dementia shares so many risk factors with other NCDs. And obviously, some of those key NCDs are risk factors for dementia in themselves. So interventions around conditions like stroke and obesity, diabetes, etc., they can have a really major impact on future dementia prevalence figures. Working closely, obviously, with the NCD community is also a big part of the success of this. That has to start to come through joined up public health messaging, sharing advice, expertise, advocating together. For the Alzheimer and Dementia Associations, I think it's also important to share these guidelines with their audiences. And I think this is where the real reach starts to come from. But also to embed it in their own work, to not just to update their websites and information leaflets, but actually to start to understand and implement and embed the guidelines as well. From our side, we have historically produced quite a simple infographic of the risk factors behind the guidelines. So we'll update that in the coming weeks and run it by you and share that as well. It's a really useful, very simple tool. And then just one thing, if I can flag, which is as part of this amplification process, in a couple of weeks' time, on Tuesday, the 28th of July, we're going to do almost like a follow-on global webinar with you. And the audience for that will be looking at how Alzheimer's and dementia associations and stakeholders can really start to implement these guidelines. There's a bit of pressure on there because they've only got 2 weeks to really start to consider how they're going to do that and respond. But if you can, go to the website and register and join that. But look, thank you again to yourself, to Katrina, and then Laura and the team, because it really is a wonderful tool. Thanks, Tarun.
Thank you, Chris. And so we look forward to your contribution to the process by converting these risk reduction messages into simple and easily digestible for the national associations, because the guidelines are global, we have to go local, right? So I know we are over time, but if I can have 30 seconds round the table on the most important action that we should be taking in the next 12 months. So Chris, since you are on screen, let's start with you. You have only 30 seconds. 30 seconds. I am going to say absorb them first, but integration and conversation and networking with right across the NCDs. I think that fully integrated approach will be how we make the biggest impact with these guidelines. Thank you, Chris. Muthoni, I'm going backwards in our through our panelists. What would you do?
So one of the most important things is to have solutions that are locally based solutions, and funding that supports those solutions, as well as research. So what I am saying is that it is important to shift power, share resources, and measure equity. That way we are able to see a faster, fairer progress.
Great. We look forward to substantial progress in Kenya. Carla, what about in Germany? What do you plan to do?
Well, this is hard because we love to plan a lot and do a lot. But since I have only a short time, I would say first, general public awareness raising regarding the 14 risk factors for dementia from the Lancet Commission, as well as educating within the care sector, targeting especially nursing, medical, and support staff. Also, I would say, to this end, the information provided that we should give for the public awareness shouldn't be abstracted for the individual. It should, as far as possible, address the individual lifestyle. And for that, the risk reduction guidelines from the WHO is a good and helpful tool, I think.
Thank you, Carla, for emphasizing the importance of awareness raising and also of healthcare providers. Closa, what do you plan to do in Brazil?
I think like we have been working here with the Minister of Health, and I think that we have already, compelling evidence regarding the risk factors and the interventions. And I think the challenge is translated this to actable endpoint of care and population level action. I think that this is a challenge, but I think here we would like to see the government and the health system in general embedding dementia risk reduction in what we already do for chronic disease prevention, and strength what we already work, identify the opportunities that we have already in what we are doing, and make dementia risk reduction a kind of standard part of primary health care and national public health strategies as well. So hopefully we are working on this with the Minister of Health, and hopefully we are going to get somewhere further than we are now in the next year.
Lots to do, Closa, and very happy to support from WHO as we can. Last but not least, Noha, what's your plan for Egypt?
I would like to say something, which is I do support all of this, but coming from our place, still we have some stigma about early detection and early awareness. So helping to raise up the stigma and started very early to work for improving the prevention of cognitive impairment since very early in life. I think this should be our message and we should raise up our generation about this, and this will be coming with the change. Thank you.
Yes, very true, Nohas. The stigma is pervasive across all societies, all countries, and raising awareness is extremely important. So, heartfelt thanks to all the panelists for joining us today. And Primrose, back to you.
Thank you very much, Tarun, and all our panelists for an engaging and thought-provoking discussion. Before I hand over to Katrine for the audience Q&A, would once again like to hear from you. And another set of questions are going to appear on the screen. In the chat, we saw that others didn't have a chance to complete them because they disappeared quite quickly. So I hope now you can get a chance to answer these ones that are on your screen. We'll just give you a minute or two. And you can let us know in the chat if you can see the questions as well. Okay, yes, I'm seeing positive responses. All right. And if you're done, you can just type in the chat that you're done. Then we'll know to close it. All right, thank you. Katrine, over to you for the question and answer session.
Thank you. Thank you all. In many ways, this feels more challenging than the last 2.5 years of updating these guidelines because you've been submitting a tremendously rich amount of questions online. Thank you so much for this. The team has worked nonstop in trying to answer many of them, and I'll just cherry pick a few of them. Please bear with me. There will be questions not answered live during the session, but we simply will run out of time. But I'll try to get make an interesting selection, and we will try to answer the others offline to the extent possible. Maybe one, before I give that floor to any of our panelists or WHO colleagues, maybe just to clarify. So the scope of the guidelines, again, did not look into what factors might increase a person's risk of developing dementia. That includes, for instance, taking certain medications or having certain health conditions. We were rather looking at what interventions are effective in treating certain risk factors for lowering dementia risk. So many questions that you've asked were out of scope or not considered. One question that was asked, though, was on how did the GDG, or in the decision-making process, cultural factors, or, for example, socioeconomic status of individuals considered in the decision-making process. And I don't know if one of our panel members, Klusa, if she would like to take that question. Otherwise, I'm happy to step in. But there's basically a framework that helps GDG make those considerations over and above what is the certainty of the evidence. Klusa, are you with us?
Yes, I am. Can I leave it to you? Is that okay?
You okay? Yeah. That's fine. So basically, in the evidence synthesis, looking at the strength of the evidence and the actual effects is one thing, but then whether or not implementing a certain intervention would increase health equity, for example, or whether an intervention is cost effective. All these considerations are carefully taken into account by the GDG and ultimately then lead to whether or not a recommendation is being made. But a point absolutely well taken. Many of these lifestyle interventions, for example, are also very closely linked to a person's social environment and might be out of their control, the control of an individual. So in implementing these recommendations, these contexts do need to be taken into consideration. Two other questions that I do like to give to any of our panelists is if they have additional practical solutions or suggestions for either low-cost cognitive stimulating activities or how to engage the older population in cognitive stimulating activities, or the same way for social connection. You know, isolation being such a big problem in the older population, how can we socially engage more? Would any of the panelists want to talk about that?
Maybe I can
yes,
share.
Please.
Yes. So I think with the cognitive stimulation activities, there is a lot of tools that can be engaged for, can be applied for the people, which is very simple. And I think there is a well evidence-based approaches that is very simple, and it is touched to the games and all the simple activities that can be shared with people, and also improving the activities within the families, which coming back and raising back the connection between the generations, that young generations and elderly generation. I think this might help a lot in breaking the social isolation. Also improving the group activities. I think making an integration of the group activities and the group meetings along with the primary care activities, having these meetings regularly and promoting for this can also help for the breaking the social isolation and coming back to the digital era and improving the connection through the digitalization. I think this is another dimension which is for the coming generation, is the who are now very much educated about the digitalization and connection with the digital might break also the social isolation. So there is many levels. So with the cognitive stimulation, coming back to the very local and the very simple, even the simple games, which raising the memories and make it culturally oriented, can help for the social, for the cognitive stimulation, group activities, coming back to the families and the connection between the generations, and finally with the digital and internet connections also can help for breaking the social isolation for the elderly. Thank you.
Thank you, Noah. I think we have time for one more question, and please indulge me in selecting one because we're hoping to increase our network. Some of the questions pertain to how can someone support or contribute to WHO's work, either to the guideline development group. Now, this work is now completed, but what other mechanisms are there for undergraduate students, but also for other members of the wider community to contribute to WHO's work? And for that, I'd like to give the floor to our colleague Laura, who's coordinating our Global Dementia Knowledge Exchange platform, because I think this might be a great avenue to do that.
Thank you so much, Catherine. I did see a few questions come up on how to get involved. There's a few networks that we currently have if you're interested in some of the work that we're doing. One of them is to help us with our Global Observatory Knowledge Exchange platform. So maybe one of my colleagues can add the link to the platform on the chat. And we have a network of peer reviewers that help us review some of the resources or all of the resources that get submitted to the platform to see if they meet a number of quality criteria for that. And then we also run a monthly dementia research dialogue session. So we actually have one coming up. It's every Wednesday, every last Wednesday of the month. And this month we'll be talking about some of the research gaps that were actually identified in the guidelines. So it will be a continuation of the conversation that we're having today in regarding how can we move the research forward to even answer some of the questions that have been asked in the chat and the Q&A that right now we just don't have the evidence for. So for that, it's a monthly dialogue session that we have, and you can join us every month. And it's a discussion type session that we run to really engage in conversation on how to move the work forward. And we'll add some of these links to the chat so that you know where to go to register for some of the networks that we're currently running. And happy to answer any questions offline as well on the work that we're doing. Thank you so much.
Thank you, Laura. And I think with this, we're running out of time, unfortunately. Like I said, we will try and get back to as many of the questions offline as possible. These are extremely helpful for us as we plan our next steps, work on implementation tools. So thanks a lot for sharing. And with that, I'll hand back to Tarun for some closing remarks. So that we finish on time.
Thank you very much, Catherine. And let me thank the WHO team, including the interpreters. I did not listen into the other language, but I hope it was helpful to have French, Spanish, and English versions of the webinar. Thanks to all our participants and panelists. I know that more than 2,500 people registered for this webinar. At one point in time, there were more than 850 people online. And I do understand because of the time zones, many of you would be listening to this video recording. So thank you for this interest in the message that is around dementia risk reduction, because dementia is one of the greatest public health challenges of our time. And we can do quite a bit to protect and promote brain health throughout our lives. We have clear evidence around many of these interventions for physical activity, for cardiovascular health, for social connection, for healthy environments, and we need to now take this forward. I think the important thing is for all clinicians, dementia prevention has to be part of the discussion when we are providing treatment and care, when we are engaging with any general public, when we are engaging with our patients. And these guidelines provide you the evidence to do so. They are part of promoting and protecting brain health, because we heard today that investing in brain health is a gain for future. And that the real measure of success is how do we translate this together into policies, services, and personal action. It requires inputs from all stakeholders. Multi-sectoral approach is needed, and lastly, what I would like to say that change begins with each of us. So as we leave today, I hope all of us can take a moment to reflect on what actions can we take in our lives to reduce the risk that is related to different risk factors related to dementia and support our brain health. Small actions taken consistently can have lasting benefits. So thank you all for your participation, your commitment, and we look forward to work together in this important area. So thanks everybody. Bye-bye. So this, I think we are at the end of the webinar. So thank you all. Bye everybody.
Bye.